Let's jump straight into this explainer. This is a clinical triage, disposition, and escalation drill. Our focus here is strictly on figuring out the next best step for triage and disposition. We're targeting high-yield escalation triggers and nailing down exactly when reassurance becomes dangerous.
Section 1. The Universal Disposition Framework.
Discharge is safe when a patient meets all the core domains. We're talking stable vitals, normal oxygenation, controlled pain, normal mental status, PO tolerance, reliable follow-up, and medication access. But escalation is required if there's any failure in these domains. It instantly changes the answer from reassurance to observation or admission, simply because the patient cannot safely sustain their own baseline at home.
Section 2. ICU versus floor admission.
Floor admission is safe when the patient requires IV therapy, serial exams, hydration, or an expedited workup, but they don't have any hemodynamic compromise. But escalation to the ICU is required when organ support level care is needed. The big clue you're looking for is shock, escalating ventilatory support, an airway risk, severe sepsis, or active major bleeding. These require immediate life-sustaining interventions.
Now, for community-acquired pneumonia, outpatient treatment is safe when the patient has a low mortality risk and can tolerate oral antibiotics. But escalation to urgent inpatient or ICU admission is required when severe risk factors or high mortality scores exist. For instance, an age over 65 combined with major comorbidities points to a fragile host, making discharge acceptable only after they've been stabilized inpatient.
Section 3. Observation and high-risk hosts.
Moving on to frostbite. Outpatient treatment is safe when rapid rewarming in a 37 to 39 degrees Celsius water bath is successful and the tissue injury is just superficial. But escalation to hospital admission for observation and angiography is required when there's deep tissue necrosis. You need that hospital observation period to allow the tissue's time to fully demarcate before you even consider surgical intervention.
What about Campylobacter gastroenteritis?
Well, outpatient observation is safe when the illness is self-limited and the host is immunocompetent. But escalation to antibiotics and admission is required when the patient is a high-risk host. Think pregnant, immunocompromised, or elderly patients. The key clue is the altered immune state, meaning reassurance is dangerous. For instance, pyelonephritis requires hospitalization and IV antibiotics simply because the patient is pregnant.
Section 4. Urgent consults and infections.
For an ectopic pregnancy, outpatient management is safe when the patient is hemodynamically stable and can receive medical treatment with methotrexate. But escalation to immediate surgery is required when the patient is unstable. Your clue here is hypovolemic shock. That indicates a ruptured ectopic, meaning discharge is literally impossible until surgical hemostasis is achieved.
Looking at blunt chest trauma, observation or possible discharge is safe when an EFAST is negative, there's no high-risk mechanism, and hemodynamic stability is achieved. But escalation to an operating room thoracotomy is required when the patient remains hemodynamically unstable despite your resuscitation efforts. The main clue is a failure to respond to fluids, which points to major intrathoracic hemorrhage.
Let's look at pelvic inflammatory disease. Outpatient antibiotics are safe when the PID is mild and the patient is completely PO tolerant. But escalation to hospital admission is required when there's a tubo-ovarian abscess, severe systemic illness, or failed outpatient therapy. The inability to tolerate oral medications or an altered host state like pregnancy are immediate admission triggers. For urinary tract infections, outpatient therapy is safe when the UTI is uncomplicated, but escalation to inpatient IV antibiotics is required when the infection is complicated by systemic signs, or if pyelonephritis shows no clinical response after 48 to 72 hours of initial therapy. That lack of response is your clue. It indicates a resistant organism, an abscess, or an obstruction that requires inpatient imaging and broad-spectrum coverage.
Outpatient management is safe for uncomplicated infectious colitis. But escalation to emergency medical admission is required when colonic dilation exceeds 6 centimeters and is accompanied by systemic toxicity. We're talking fever, tachycardia, or hypotension. This indicates toxic megacolon, which requires immediate bowel rest, decompression, and IV antibiotics. Watch out for the exam trap here. Enemas and colonoscopies are strictly contraindicated because of a high risk of toxic perforation.
Section 5. Social disposition barriers.
It's really important to remember that outpatient disposition is safe when the home environment is secure and supported.
But escalation via social work, case management, or even hospital admission is required when a patient cannot reliably access medications, lacks transportation, faces severe language barriers, or is just unreliable for follow-up. The clue is a lack of resources. A clinical safe discharge becomes an inpatient admission simply because they cannot safely execute the care plan at home.
Section 6. Rapid Safe Discharge Drills. Let's run through these.
First, nephrolithiasis. Outpatient management is safe when stones are under 5 millimeters and the patient maintains oral hydration with adequate pain control. But escalation to an outpatient urology consult is required when the stone is over 10 millimeters, causes persistent pain, or fails to pass in 4 to 6 weeks. The clues here are size and time, since prolonged obstruction risks irreversible kidney damage. For our second drill, looking at an evolving abdominal process, observation is safe when you have stable serial exams, like an isolated Robsing sign indicating acute appendicitis without peritonitis. But escalation to immediate surgery is required when rebound tenderness or involuntary guarding is present. The clue is peritoneal irritation. That indicates rupture or impending rupture, making conservative observation highly dangerous.
Drill 3. For suspected osteomyelitis, observation or empiric antibiotics are actually unsafe. Escalation to a bone biopsy is required first to ensure targeted therapy. For Hainig-Schönlein purpura, observation is safe when symptoms are confined to a puperic rash and arthritis. But escalation to surgical management is required when ilio-ilio intussusception occurs. The clue is small bowel involvement. Unlike ileocolic intussusception, it can't be treated with an enema and requires an OR.
Last drill. For COPD exacerbation, outpatient treatment is safe when symptoms are mild, but escalation to antibiotics and inpatient treatment is required when patients meet 2 gold criteria features, like increased sputum and dyspnea, or require mechanical ventilation. For acoustic congestion, observation is safe following a stable presentation, but escalation to inpatient monitoring and endoscopy within 12 to 24 hours is required when heavy drooling, dysphagia, and a white tongue indicates severe esophageal injury. Mastering these exact escalation triggers is the key to safe and accurate clinical disposition.